Hello, my name is Peter Nilsson. I'm a professor of clinical cardiovascular research from the Lund University in Sweden. Today I'm in Milan for the European Society of Hypertension meeting, starting today, and I gave two presentations on the role of SGLT2 inhibitor drugs for control of cardiovascular risk and effects on hypertension. As you know, there are many new anti-diabetes drugs with a great importance also for cardiovascular prevention. One class is the so-called SGLT2 inhibitors. They promote glucosuria, they lower blood pressure, they lower glycemia and body weight, but in fact people don't really know exactly how they work. What we know already is that there are 3 large-scale clinical trials showing cardiovascular benefits: the EMPA-REG trial, empagliflozin, the CANVAS program with canagliflozin, and the DECLARE study a few months ago with dapagliflozin. They were all more or less successful, especially in secondary prevention in patients with type 2 diabetes and previous cardiovascular disease, less effective in patients with multiple risk factors alone, but also in these patients there were shown benefits for protection of the heart, a decrease of hospitalization of heart failure. That is very important because not all cases of heart failure depends on previous coronary artery disease. Some cases of heart failure in diabetes are dependent on diabetes cardiomyopathy, another process. So basically, these new drugs are effective. They have not so serious side effects. Some urinary infections may occur, also some other adverse effects, but in general, they are rather safe. So, as you know very well, many patients with type 2 diabetes also have hypertension. And this is why I want to focus on the blood pressure control of these new drugs. It has been shown that they reduce office blood pressure a few millimeters. They can also reduce 24-hour ambulatory blood pressure with some effects, a few millimeters of mercury, but a constant effect. And now we wonder why. As I mentioned to you, there is glucosuria, there is natriuresis, there is weight reduction, and people think they also improve central hemodynamics, lower arterial stiffness, and altogether this could mean improved blood pressure control. This is very, very important from another perspective, because the prevention of heart failure occurred very early in all 3 clinical trials versus placebo. This means that something happened very early to protect the heart. It could be either an improved cardiac metabolism. Cardiologists often think that. Studies are ongoing. But on the other hand, there could be improvement of central hemodynamics, because we know that everything that improves blood pressure and central hemodynamics will lower the burden of the heart, will unload the heart, and thereby reduce heart failure risk. So, to sum up, these new drugs are beneficial for risk factor control, blood pressure reduction, prevention of composite cardiac endpoints and heart failure, even renal endpoints protected. But we also have another class of new anti-diabetes drugs, the GLP-1 receptor agonist. And recently we had some new trials. Previously we had LEADER trial, we had SUSTAIN-6, various drugs, liraglutide, semaglutide. Now, recently at the ADA, we learned about REWIND trial another new GLP-1 receptor agonist and also the Pioneer 6 trial using orally active semaglutide. The take-home message is that these drugs are also cardioprotective and they reduce blood pressure to a certain degree. However, they may increase heart rate, not so much, but to some degree, and this to me is an indication of vasodilation, because whenever you get vasodilation on a hot sunny day, your skin is very hot and warm, you get vasodilation, and secondary to that is increase of heart rate. So taken together, this makes me think of vasodilation as one mechanism that GLP-1 receptor agonists could lower blood pressure. So now we have new guidelines. Last year we saw new treatment guidelines from EASD and ADA promoting the newer drugs, especially in patients with type 2 diabetes and a previous atherosclerotic cardiovascular disease event, like secondary prevention. Now, this year, I've been told that at the ESC meeting after the summer in Paris will be launched the new set of revised guidelines on cardiovascular prevention in diabetes and impaired glucose metabolism, written by the European Society of Cardiology in collaboration with some other societies, because the previous set of guidelines was in 2013. And over the years, now 6 years, so many new things happened, and I think a more focused role of the new anti-diabetes drugs will be visible in the upcoming revised cardiovascular prevention guidelines. Now we are at a hypertension meeting, and I'm really glad that 2 symposia at least addressed treatment of diabetes. Also in some other symposia during the weekend there will be more information about hypertension in diabetes, as these 2 aspects are so tightly coupled.